Good evening, everyone, and welcome to the last meeting of the HOSC of this municipal year. It seems to have gone really quickly. Thank you for coming tonight, and thank you also to those who are online. Are there any apologies?
Yes, Councillor Shepherd-Bay, who's being substituted by Councillor Caroline Smith, and Councillor Rance is online.
Thank you. Are you happy that I signed the minutes of the last meeting as a correct record of our meeting?
Yes.
Thank you. One yes will do. Are there any declarations of interest? No. Any public questions?
No questions.
Thank you. Any town and parish questions?
No.
Any councillor questions?
No.
Thank you. We should be finished in about 2 minutes at this rate. Voluntary and community sector prevention contracts. Who's taking this? Oh, sorry. Health Watch. Alice.
Hello.
Nice to see you. Sorry you're not well and not with us. It's you next on the agenda, the South Asian Women's Report.
Yes. So just to, thank you, everyone. Good evening, Chair, and good evening, members of the committee. For those who don't know me, I'm Alice Pinnippi-Clifton. I'm the lead officer for Health Watch, and thank you for giving us the opportunity to present our report. We are here to share with you two key pieces of work. One is our South Asian Women's Report, which is one of the first reports that has come to HOSC, actually. And without further ado, I've got Natasha Khan, who's our engagement officer, who will present the findings of the report and also sharing what are the experiences and the barriers that they've had. After Natasha's done her presentation, we are happy to take any questions you may have before we move on to the second part of our session. So without further ado, I'm handing over to Natasha.
Good evening, everyone. So my name is Natasha Khan, and I'm the Health Watch Engagement Officer for Wokingham. So today I'm going to be presenting an overview of the South Asian Women's Health Project. I believe many of you may have already have seen the full report. It is up on our website. So this is just going to be a brief overview and just talking about why we did this piece of work and what we heard and some of the outcomes that we've seen so far. So, we could go to the slide. Okay, so we had several clear reasons why we undertook this project. And firstly, health inequalities, it continues to be a consistent kind of concern for residents in Wokingham, and particularly through our annual Have Your Say survey. We also kind of recognise that within these communities, there were certain voices from diverse communities, particularly the South Asian communities, that we were missing from feedback and engagement that we regularly kind of conduct. And that to us kind of stood out, as we know that 20% of Wokingham's population is made up of ethnically diverse communities, of which the South Asian community is one of the largest. We also did the GP Access report. And within that, we really did not hear enough from the South Asian community. So this project was very much targeted to hear the voices of those communities, and also in alignment with the National Women's Health Strategy and the Marburg Principles, where we're really wanting to hear about emphasising prevention and tackling inequalities in healthcare. Next slide. So just very quickly how we did it. We really wanted to ensure that this was a very targeted programme to make it as relevant as we could for the community we wanted to hear from. So we did some data mapping. We worked with public health, and we identified the key demographic groups and priority areas within the borough for targeted focus. We did a range of surveys, both online and face-to-face, to just ensure it's accessible to everyone. We provided this in different languages as well, again, to make it as accessible as we could. We also did conduct an online focus group as well to just dive a little bit deeper into the challenges that the South Asian women face, any barriers and challenges they face when they're accessing healthcare services and information, and really asking them what are their thoughts, and share ideas for improving services, women's services. So we did a lot of local engagement, and we worked a lot with community groups and with faith groups as well. And actually, being Pakistani myself and having the support of the community connectors, we really helped to build that connection and get a cultural understanding, and it made the participants very forthcoming and willing to share their experiences. So that worked really well. We collaborated a lot with partners and networks. We worked with Citizens Advice Bureau. We worked with Cranston, other organizations. We shared this as widely as we could with local businesses on social media, GP surgeries in the key areas where we were targeting. And all in all, we got a total response of about 115 women who took part in this. Right. So again, this is just a very brief overview of some of the key findings which made up some of the main themes of our report. And so 50% lived with a diagnosed long-term condition, and that just shows the importance of them needing ongoing accessible support. This figure could actually be higher than 50% because there were actually 30 participants who had also selected some other long-term conditions which we had not listed. So this 50% could potentially be much higher. Within those 30 women, a lot, about 9 of them mentioned thyroid disease, thyroid related. And we know that certain hormonal conditions are more predisposed within the South Asian community. So that also did come up in our report. A very large number, 89%, wanted a wider choice of evening and weekend appointments, indicating that flexibility is really essential in improving access. Now, out of our participants, 75% were in employment, so whether full-time or part-time. So for them, this comes as no surprise, this figure of wanting weekend and evening appointments. But 51% did not feel confident with online booking, and that's a really concerning figure. So when we're talking about online booking, it's not just the appointments, but it's just navigating the online systems as well. And as we see with the NHS moving towards more of a digital space, this is something that we really need to ensure that we're not digitally excluding the communities. 47% wanted the option of requesting a female practitioner. That would make access easier. In fact, some women also commented how they would potentially delay or not receive treatment if it was with a male practitioner. Well, one lady that we spoke to, she had a UTI and she waited for 4 weeks until she could actually get an appointment with a female practitioner. So within this community, the female practitioner is actually quite a strong theme that came out. 82% of women wanted healthcare information and communication, which was easy to understand. And even though 95% of the women in our report said they were English literate, I think this level just goes to show that it's not just language that is a concern, it's the understanding of medical terminology and being comfortable with the communication. So all in all, with that, we had these 4 themes that came about. One is access to booking appointments. The other is the importance of having a female practitioner. Long-term health conditions came out very strongly on this. And also health literacy, health literacy itself is understanding and navigating healthcare systems. Next slide, please, Alice. So as mentioned, the full report is out. It has been published. It's been shared with Bob ICB, and we're just waiting for a response on that. The report, it has every theme has a list of really actionable recommendations on how to improve services and how to engage the community further. And as part of this report, Alice is also working on this in terms of helping to really shape the neighbourhood health planning guidance as well. Key health literacy indicators were identified in the report, and this is something that we are going to explore further with the use of community connectors, because what we know is that lower health literacy does lead to greater health inequalities. So we really want to understand and build trust and understand from these communities what the barriers are further. We've had a lot of positive feedback from community groups with our reports so far. I think Alice might want to share a bit more, but Reading Community Learning Centre, they expressed a really strong interest in collaborating further on the findings, as the women who attend their community centres, they were also experiencing the same kind of themes, the same kind of barriers. And it really just goes to show that, you know, this report is not just localised to the South Asian women in Wokingham. So that was a very brief overview of the report, just some of the feedback. We made some very good, strong relations with the community groups and community connectors, and we're really hoping to capitalise on that further for our health literacy report going forward. If there are any questions, happy to take them.
Caroline.
Thank you very much for that thorough report. It was interesting, and with the outcomes, are we going to go back and visit it in a few years' time to see if there is some improvement? Now we've got lots of initiatives or ideas. Thank you.
Shall I answer that?
Yeah.
Thank you, Angela. Yes, yes, we will be. I mean, at the moment we are reviewing all our reports anyway, but we will be, as long as we are still around. We still don't know the future of what HealthWatch is going to be in a couple of years' time. So I do think that this report can be used a little bit further into the neighborhood health. So, and I think there will be an impact on it, especially with how to engage with the communities that are said to be hard to reach.
Rebecca.
Hi, Alice.
Hello, hi, Natasha.
It's a good report. Obviously, you've made a lot of great recommendations there. And I think, to be honest, there's a lot of recommendations that I think all women would like. Yeah. And this all stems down to, as well, the disappointing news that we had kind of last year when the Women's Health Hub, we were only just a trial, and it closed down, and we don't have that as such anymore. So I think these issues can be addressed, and with the kind of move that we're hearing to this neighbourhood healthcare as such, the Women's Health Hub would be an extremely valuable thing for Woking Borough, and women in Woking Borough should get that. All races, colours, everybody should receive that regardless. So I hope you can help put some pressure on to get that resolved.
To be honest, I'm glad that this report is out, but also, we have to also celebrate that Public Health has put out, has commissioned a service for women's health in Wokingham. So all we need to do is enhance that a little bit more, to be fair. So I would say that, we just need to do that a little bit better and work with the GPs. But I'm hoping that as far as I'm just waiting for the Bob ICB to give us a response of what how they will take our recommendations. But I don't think this report will be quiet. It will be used for all women.
Alice, I think you're right. I think you've pulled out some issues here that apply to many of us, especially older people and ethnic people, apply to everybody's access, a lack of appointments in a timely manner that we want and need, and all sorts of information that we would like to have in an easier format to understand. And so I think you're fighting on behalf of many women in this country, not just ethnic minorities. We agree across the piece for a lot of what's in the report. And so we look forward to it coming back when we've done some more work on it. Are there any further questions for Alice? Mike.
Thank you. Thank you for your report. And I guess echoing really what's already been said, I guess if you ask the same questions of a much wider cohort, you get similar answers. It's interesting to see that what would make it help easier was specifically outstanding was the more wider choice of appointments. And I was interested to see also that there wasn't a huge amount of agreement about the cultural and religious beliefs were respected. So I guess I'm wondering, how can we, increase the response, because 115 wasn't great, and how can we also, what can be done to try to improve the respect for specific cultural or religious elements of what goes on inside an appointment, please?
Thank you, Councillor. Just to share with you, when we did the GP access, we hardly had any communities come forward and give their experience. So in a lot of ways, I wouldn't say the numbers are bad. I think this is one of the biggest reports of diverse communities that have come on board. And I think a lot of this comes down to trust. So if they, we went out to them and spoke to them, and and that's how they shared a lot of our findings. So I think engagement with them and being respectful of their cultural needs was one of our biggest strengths, especially, Natasha made a big effort in translating a lot of the materials into their language as well. So those were the things that we were very, very respectful of their ways and tried to engage with them. And what we were trying to do is showcase the different methods of engagement, especially for those who were called the hard to reach.
Any more questions on this report? Thank you, Alice, and thank you for all the work that's been done on this. And it's your show tonight, really, so you're on next as well, Alice.
I mean, just to share with you that this report is now also will be showcased in the South Asian Heritage Month as well in July as one of the reports, because it's all about health inequalities and what these communities go through. So that's one of the things that's also been will be taking place. But yeah, I mean, I think in a lot of ways, whatever reports that we showcase, we try to make sure that I'm hoping that this report will show that actually, yes, these communities are called the ethnic communities, but more women are the same. They all they want access to services easier, and their carers and all those. I just think that I'm hoping that this report will showcase that these women are no different to any woman, and that's what I would like this report to be. Anyway, I have shared with you all our activities, and I'm not going to prolong it. And I just want to. I'm hoping that there are any, you all understood what I was trying to share, and if there is any questions you would like to ask, please do ask, because I don't want to repeat things that are not needed. So I'm happy for you all to share with me any questions that you would like me to answer.
Thank you. I trust we won't shout them, though. Any questions for Alice? Any nicely spoken questions for Alice?
It doesn't have to be nicely spoken if we need to.
I'm being nice to you. Don't stop. Any questions for Alice? Rebecca?
The dreaded Wokeum Medical Centre, Alice.
Oh, yes.
Are you
Yes.
getting anything positive from it, or are we still in the same situation that,
No, I think I think in a lot of ways they have engaged with us a little bit more, a little bit better. We lately shared with them about someone tried to access their PPG group and couldn't get past the receptionist, and I reached out to the practice manager, and she has engaged and said who to contact. So we're getting there slowly. We will get there. I mean, the thing is, though, I mean, there are some good points part of medical center that people are, some people say that they are friendly, some people say they are being challenged. So but I also would like to say that it is now going, I think the services as at a large, not necessarily working in medical center, but the GP services are going through challenging times because the changes that are taking place through the new NHS 10-year plan is very challenging. And having to change to their new way of working and things. To be honest, the workforce are struggling. So we will still persevere as long as we are here. They don't like me writing to them anyway, so they have to respond within 20 days of us writing because that's one of our statutory powers, and so they have to respond. So so far it's been so good, but I personally think it's because they are one of the largest surgeries compared to the others, and we might get more feedbacks, negative feedbacks from them because of being large, but we will still persevere. Their themes are the things that we are hearing are no different to the other surgeries. We still have GP access pressures, digital access pressures, that and the NHS app is one of the biggest challenges that we have.
Thank you, Alice. Do you want to come back, Rebecca?
no, you said about the NHS app, it's good to see that our younger residents and families are reporting benefits from it, but it's obviously still us old crones that are struggling with it. And it doesn't seem to be, I know we had somebody here, I can't remember who it was, one of our last HOSC meetings, who told us all about how everything will be digital from now, and it wasn't happening at my surgery, yet she told me it was. So I just wonder what feedback you're getting as how streamlined it is, because there still seems to be two systems you can ring up, or nobody seems to be clear of which way you should be doing things still, although we were reassured that wouldn't be the case.
So I have shared with you that we got over 900 feedbacks, which is such a big feedback from Wokingham. And the thing that the young people, what they shared with us was the fact that they can download, but it was the process of getting through the GP system was the difficulty. So now we are working with the young people to try and make sure that they understand the process. So that's coming up. But what we have also done is just to share that we have shared our preliminary findings with Bob ICB about the logging in and verification, low access to features and all those kinds of things. But the thing that we have learned is the fact that it is not them that's going to be controlling the NHS app. It'll be the GPs. So now we have to go back to the GPs and find out what is put in place for them to make it better. So this is all coming out now because with the changes that's taking place with Bob IC becoming Thames Valley ICB, there's going to be quite a lot of changes. But, we will still persevere. We will still share our findings and with the surgeries as well. I mean, one of the things that we are also learning, Councillor, is the fact that the the application of the NHS app is inconsistent in different surgeries. It's not consistent.
Alison.
Hello, Alice. Could
Hello.
you tell us some more about the Health Watch Wokingham activities with measles prevention and local outbreak monitoring?
So we get national information about what has been happening, and then we sort of share. So, you know, we are about sharing all the information that's been taking place. So we share locally what has been happening and try and get feedback from the community of what is their experience locally. And that's what we are trying to do. A lot of our stuff comes from what nationally, what is happening nationally, and then we try and get feedback locally, because we don't hear a lot, and and until we hear something, I try and go to public health and find out a little bit more, but we haven't heard anything locally as yet. But it's very much what we hear from we're from national, we share. A lot of our activities are very much that way inclined as well.
Okay, thanks, Alice. Caroline, may I ask, is measles a outbreak a concern in Woking Borough?
Thank you. Measles is a concern nationally, and we are seeing some outbreaks in other parts of the country. We're not seeing outbreaks in Wokingham. We have very high rates of vaccination amongst our 5-year-olds. So we expect two vaccinations by the time you're 5 to achieve that sort of herd immunity within our community. So we have 95.2% are vaccinated once, and 94.1% are vaccinated twice by age 5. So that's really high compared to lots of areas. I mean, obviously we don't want to be complacent, continue to try and encourage uptake across the board, but we're pretty good at managing that in Wokingham, and we certainly have not seen those sorts of outbreaks that they're seeing elsewhere.
Mike.
Thank you, Alice, for the report. Just a comment on the NHS app. I mean, I find it very easy and useful tool, but what really annoys me is the fact there's no joined upness between the GP records and the hospital records. Although I found out recently that the GP can download data from the hospital records if they choose to, or if you ask. But anyway, moving on. I was a bit more alarmed to hear on the news that there's been a meningitis outbreak in Kent, which has resulted in 4 deaths, one of whom was a school child or school pupil rather than a university student. I was just wondering what in Wokingham do we have in terms of early warning or other measures to nip it in the bud if it becomes a problem.
Onto that. Yeah, it's really, really tragic what's happened in Kent, and it seems to be an incredibly aggressive strain of meningitis. So anytime anything like that's reported, that will be picked up and reported to the UKHSA, the Health Security Agency, and then links will be made with the various universities or contacts of the people who have come down with that condition. We'll be involved in the health protection team in the local authority, but the UKHSA will do the contact tracing and prophylaxis vaccinations. We also have a meningitis vaccination programme. So the idea is that you've got a fully vaccinated population by the time they go to university. That doesn't always happen. And so we run a further programme in like Freshers Week to try and encourage uptake of vaccination. I've asked the health protection team within Wokingham Borough Council just to link with the UKHSA locally to check whether there's any further information we need to send out to, for example, Reading. Obviously, normally we would send out warn and inform notifications where there have been cases. We haven't had any cases yet. So we'll work with guidance from the UKHSA to follow that through.
David.
Can I just add to that my wife was saying that this area is well vaccinated again against that, so that's very positive, because the better your vaccination, the better herd immunity.
think one of the issues with universities is that it's not always your resident population that attend them. And so, you know, that's why it's really important that when we get new students in, we just kind of do a review and try and encourage that full vaccination.
Mike?
Slightly different question. Under the review of the negative resident insights on the surgeries, all three have got prescription issues. Could you just enlarge about what those prescription issues are, please?
We've had people to turn around and say they could that they couldn't read the prescription. Was one that. The other thing is also dosage as well. So those were the things that we were getting. And the other one was the link between the surgeries and the pharmacy. They couldn't get the prescription on time. So it took longer. So that was the three things that we had.
Okay, being a resident, I'm slightly surprised to see Brookside there because they're very, very quick for anything I ever ask for. Perhaps
Yeah.
I ask for anything weird.
I think, just as I said, sir, I would turn around and say a lot of this is not. I know some people are happier with Brookside, some people aren't, but I wouldn't turn around and you know, I think they are far more forward thinking than some other surgeries I know. Please don't tell them that.
Are there any further questions for Alice and Health Watch? No? Thank you, Alice. Lovely to see you. You're welcome, of course, to stay for the meeting, as always. Item 78 on our agenda is lessons learned with the cessation of physical activity services. Caroline, are you leading on this?
I am. I'm just going to share my screen. Where are we? Has that come up? Sort of. Let's see if we can get it from the beginning. There we are. So you will have seen the paper in the pack that we were asked, in fact, we offered to pull together a lessons learnt paper following the review of the public health grant and how we... Sorry, it's not, okay, yes, sorry, I do. There we are. So this is a paper that we pulled together to look at the lessons learned following the decisions that were made to realign our public health grant that led to the cessation of 3 physical activity programmes. So the report itself provides a very detailed update on the background of the situation. It documents those lessons learnt. It describes where in the pathway we could have managed things better. And it looks at how we addressed the issues that we identified. So the Health Overview and Scrutiny Committee is asked to note those lessons learnt, acknowledge the comprehensive response that we took to address those issues raised, and to note as well that improved collaboration with Places Leisure that have helped to build on those partnerships that we already had. So the key points that I've identified in terms of those lessons learned is really an improved understanding, mitigation, and the timing around the impact on service users, to include clearer transition planning for people who are displaced from those programmes. Improved consultation with staff and service users. I mean, that was impacted by some of the HR timescales, but that doesn't mean to say we couldn't have done things better. And more personalised and more detailed communications with service users, providers, counsellors, and our executive. So some of our headline numbers, as we've been kind of crunching the numbers through this, we contacted 366 people who were registered since the 1st of August. And we contacted all of those people. Not all of them had been active on a programme, but they were all on our registers. And the current position is, of those 366, we've engaged with them all. 181 are now on a new programme or about to be on a new programme. 33 need a new GP referral, and the remainder are not interested in progressing a referral with Places Leisure. And then we obviously have received a number of complaints or queries regarding that process, and that was 34 people. And we have a breakdown of all of those, but I'm assuming we don't need to go through all those unless those come up in issues, but yes.
There's a lot more information in your slides than is in the report. Yes. So are you going to have the slides attached to the minutes?
You're welcome to have the slides, absolutely welcome to have them. That just provides the detail that I was going to share if there were any questions particularly relating to those issues. So it's any questions, really. So these slides just provide, so these slides provide detail of some of the actions we've taken and information we can give you. So of the 366 people who were registered with a programme, 47 hadn't attended any sessions, 37 had attended less than 5 classes over those 20 weeks. 121 had attended between 6 and 10, and 161 had attended more than 11 sessions in those 20 weeks. And 5 people had attended more than one a week. And all those 366 people have now been contacted and have we have supported them to an alternative programme. So this details that process. It's a bit too small to see, but it tells the details of the number of people who didn't want any further contact, people who haven't continued to communicate with us. And this provides detail of the people who've raised formal concerns or queries with us. So 28 of the 43 communications that we had came in the week before Christmas. So that was that week in which we communicated with people that the programmes were going to stop. And as a result of those 28 communications, we put out some much more detailed information, and we established a support programme to support people onto different alternative services. And of the remaining 34 who didn't talk about a refund, the issues raised were about concern regarding the process we took, information requests about the rationale, queries about specific equipment availability, and then wanting support to move to suitable alternatives. And then the other table was about the costs and activity. So what the cost of the service was to public health, which can show you the degree to which we've been able to use that funding for other activity, and then how the services were used by service users. And you can see it's quite significant. So, for example, for Steady Steps and Long-Term Health Gym, we needed 2 members of staff, and sometimes we had no people turn up, and sometimes a maximum of 6 people turn up. So you can see the kind of cost of this service. I think that was it, really. Yes, it was just.
Caroline, we will send out a copy of that so that you can have a look at it later on. Right, Rebecca first, please.
Well, I've got a couple of questions. One of the things I did want to ask about costs, but I'll have to come to that second. So in your report, you talk a lot about lessons learned, and most of them are action that you've taken following what's happened. But what I wanted to know, and I've never really been able to get to the bottom of, is why we only had 5 or 6. You thought there were only 5 or 6 people on the programme, and actually there were over 300, because that's a significant cost. That's being paid for by the council. So what is the lesson learned from that, so that people that come onto these courses, they do the programme, they're signed off it, or they're signposted somewhere else? What we taken away from that? Because you haven't actually identified that at all as to why that happened, why that's been allowed to happen. That has built up over a considerable period of time. It's not just happened overnight. There's nothing in here really to say about the cost, how much that was costing us when there were all these excess people that shouldn't have been on the courses, against who you thought it was. And okay, you've saved money by making people redundant, but where this really balances out, because we haven't seen those figures until you've put them in the slides this evening. So it's still quite hard for me to get my head around it without looking at it. So I don't know if you can kind of cover that, because I know I've had a meeting with both you and Matt, and I've still never ever been able to get to the bottom of how we could understand there are only 5 or 6 people on these courses. You thought that when you closed it, it would only affect that many people, yet it was such a large amount of people.
Yeah, so I think this is... So first of all, you're right, these things don't happen overnight. So these courses have been in place since 2014. So they've been going a really long time, and they were based in a different department. And as we disaggregated the public health from a Berkshire-wide approach and brought it in-house, we were able to look at more the detail of where that funding was going. And that identified that these courses were funded by public health. So they weren't funded on a tariff basis, it was on a staff basis. So that the numbers of people who attended didn't affect the cost, it was just a high cost service. As we identified that they were being funded, we brought it into public health, because then we can start to look at how we're managing that. The 3 programmes were 12-week programmes, and the aim of those programmes was to move people, or to build people's confidence, to move them into mainstream or adapted activity. That didn't seem to happen, and that had built up over a period of time, to the point that even staff, service users, it wasn't even in their radar that this was a set programme period of time. So the 5 people were the people who were new to a programme, and so that's where we are. That's what that headline figure was. So it was those 5 people could reasonably expect to finish that programme they were on, and we honoured that with them. What we didn't properly understand was the impact on people who'd maybe been on these programmes for years and years and hadn't really been appropriately supported to move on to other programmes. That's where that discrepancy comes from with that 5.
I understand the discrepancy, but to then cut a service for that volume of people, it still doesn't make any sense to me. I still struggle to get my head around it. I do appreciate your report, and I appreciate the fact that at the end of it, you do apologise. And I'm not saying this is personally anybody's particular fault. It isn't. But for me, this whole experience and what has happened to residents, I actually spoke to somebody on the doorstep about this at the weekend, even to the extent that when they had the meeting with Places for Leisure, the latest meeting, there was not one person from the council there. It was all Places for Leisure. And apparently it was awful because you had so many angry, upset residents. It turned into a shouting match. It's just been so poorly managed. But it does seem now that you're getting to a point where the need is being addressed and you've found ways to accommodate them. But I think what I'd like to know is how much has that cost? You know, to sort this mess out, the additional cost, how are you now finding the money to accommodate? I know people are being asked to pay for a gym membership as well now to through Places for Leisure to attend some of these classes. And there are lots of people as well that would have been happy to continue to pay for these classes. They wanted them. They were a lifeline to them. So how much are you able to provide us any figures? I don't know if it says up there, I can't read it very well, it's too small, but to say how much this has cost us to sort out?
I mean, it's the cost for what we've put in place is a transition programme at £5,660. So that's the cost of the the programme that will support people further into those activities that they should be doing. What we should have done is put that in place before we stopped what we were currently doing. That's absolutely the case. So that's where we are with that. These are the numbers of people that attended classes. I would like to say that I think there were people who felt it was Places Leisure had stopped a service. And so that very first meeting that Places Leisure had, they did receive a lot of negative feedback on that. This is not Places Leisure who stopped that service. That was us.
That's what I'm trying to say to you, Caroline, is there was no representative from the council at that meeting.
Not at that meeting, but all the subsequent meetings there were. We attended all the subsequent face-to-face sessions. It was a surprise to us and to Places Leisure that happened. No one would have wanted to put Places Leisure in that position.
Matt, did you want to come in there?
I did, yeah. I mean, I think just to reiterate the apology, really, in that we brought back the public health service from the shared arrangement because a number of the commissioned arrangements we wanted to get more control over, more oversight of, and you know, some of those will come up later in the conversation. And I think the honest truth is that we've had a year where we've struggled to recruit a DPH. We've had interim arrangements in place, and some of those impacts were missed by their staff. We've changed that now, but you know, I think that's the honest truth. What we should have done here, the idea to create the efficiency in the public health grant to move people onto equivalent courses because they were available was not a bad idea. It's just that because of those things I've just said, we didn't understand the impact before we did it, and we should have put those transition arrangements in place like we have done now before we made the decision, and that would have vastly reduced the upset to residents. So I just, you know, personally apologise for that.
Thank you. Nagy.
Caroline, did you guys speak to the staff members who are delivering these sessions? Because when I looked at the graph, I mean the chart which you presented, it looks like a lot of attendees at different sessions. So when you're trying to take this service off, did you speak to, or did anyone speak to the staff that are delivering the services?
Yeah, so we have really clear HR procedures that we need to follow, and we had a full consultation period with the staff affected. Yeah.
Yeah, that is fine, but was patient involved, or the people who are receiving these services being asked, like, how many do you think are attending the session? Because at the end, we came up with number 5 or 6. So if you would have asked this question to the staff, they would have told you these many people who are attending the sessions.
So Caroline wasn't here then, and I suppose that was when those interim arrangements were in place. So it's hard for me to find out whether those conversations happened or not. They should have done, but you know, that's part of the apology, I think.
You finish and then Prue can come in.
As Rebecca was saying, we hear this a lot at the doorstep. So is it possible to, I know it might be patient confidentiality, is it possible to give a list of users or something for the counsellor so that, or what sort of measures have been in place so that next time when we speak to them, say, this is the contact you have to speak to?
So we can't give you individual names. You can give us individual names. So if you have people that you're speaking to that have been affected by this, then please do let us know, because we have those lists of everybody who was on one of our programmes, and we triangulate that with Places Leisure data to show how people are moving through into Places Leisure. So if there's someone who has fallen through the net, definitely let us know.
Is there anything we could give to the patients or residents, just in case, like a handout or something, so that they can get in touch with you directly?
Absolutely. And we have circulated a lot of information about how people can get on suitable alternative programmes. But you're more than welcome to give them my email address. I've taken email communications from people.
Prue.
Thank you, Beth, for letting me speak. I'm conscious that Rebecca probably is still none the wiser about how this arose. And I think the genuine answer to that is it's so long ago that nobody knows how we ended up like this. The service started in 2014. It was somewhere else and run. And Caroline has been with us less than 6 months, I think, has picked this up. And I think personally from the executive, we're very grateful to her for everything she's done to sort it out. We shouldn't have been in this place. We all apologise to everybody. There are alternatives which will suit the vast majority of people. There are some people who, unfortunately, whose health has deteriorated and should be picked up and looked at by their GPs again. We would fervently hope we would never be in this situation again, but we don't really understand how we got here, and I'm not sure we're ever going to be able to get to the bottom of that, and it's not for want of trying.
Mike.
Thank you. Thank you, Caroline, for being so clear about what has transpired. The information in the slides would have been helpful. Yeah. Perhaps, never mind, moving on. The lesson learned that hasn't been stated, I guess, is that, well, if somebody's commissioning something from a provider, that's effectively a contract, and I don't know what the arrangement was between us, Places Level, whoever was it put it in place 12 years ago, but somewhere the costs must have escalated well beyond the original budget. So I'm wondering, what are we putting in place to check anything else like this isn't running away with itself a bit like a runaway train down a hill? And how are we going to prevent anything like this happening again going forwards, in terms of there must be a relationship between the provider and the commissioner to say exactly what's expected of them? Because I'm guessing that people were told they were on a short-term course, although if one of them was called long-term health gym, that's kind of a bit of a misnomer. And I assume that Places Leisure knew they were supposed to be on a short-term course. Oh, okay, all right.
I think, Mike, this is the thing. It wasn't commissioned through Places Leisure. It was our public health staff or staff within the council that were delivering these programmes. So it didn't actually increase in value because we just had those same members of staff. And in fact, we had a vacancy which we didn't recruit to. So it wasn't through Places Leisure. And as Prue said, it's been going on for so long that I think the rationale for the programmes had got lost in time. I'm certainly strengthening the commissioning and service agreements that we have and how we monitor those within public health, because that's important for me. I've come in to do this, and that's what I want to do. I think it's a legacy situation that we've identified and we're doing something about.
Okay, and I think the figure used, I wasn't sure whether the figure was 43 complaints or 34 complaints, but in the greater scheme of things, that's 10% of the people who are on the course, and it's a tiny, tiny proportion of the population that could probably benefit from subsidised physiotherapy or whatever. So hopefully we can put it to bed and move on.
Thank you. So it was 43 people wrote to me. Of those, 9 of them just wanted a refund. And we do have a refund process, but they came via me. So they weren't really complaints as such, they just wanted a refund. So it was 34 that raised more detailed issues. And you're right, that's about 10% of people who were registered. Yep.
Relatively small portion, because I'm sure lots of people will benefit from rehabilitation work in the gym if they have the will and the willpower and the ability to do so. Thank you.
That's true, and it's worth just saying that people do still have that subsidised access through Places Leisure now. So, I mean, that's still there.
Sorry, Alison. Sorry? Sorry, yeah. I thought you'd been. Yeah, sorry.
I'd like to ask if Councillor David Harris, lead member for Health, was aware of this and signed off this decision before any residents were contacted.
This, because it was not cancelling any arrangement, was an officer decision. I take responsibility and I apologise for what happened, but it was an officer decision because it was not removing a service. It was moving a service, but it wasn't removing a service, and so that was what was important. And I mean, in fact, it started spilling out with the users before it should have done, because the people who were running the service let some of them know, to be quite honest.
I'm going to defend David here, because at the point that when this all started and they were looking at it, they thought there were only 5 people involved and that people were being moved onto a different delivery mechanism, but effectively the same service. And having officers discussed it inside the council, and that was thought to be an operational decision. So David wasn't asked to make a decision on it. Had we known then what we know now, we wouldn't have used that process. We would have used a different process, but we didn't. And so David didn't really have a decision to make.
Okay. So I suppose if
Yeah.
had known what we know now, like a lot of other changes, you know, the change to the Westmead to Matthews Green, if you remember that. I would have bought. We would have bought a paper here and discussed that before the transition plans. So.
I know you discussed the number of people who wrote to you who are directly impacted, but I think there are an enormous amount of people across the borough who are aware that a change was in place, and you know that family, friends, people they knew who had been affected. And I wondered if we need to really try and spread some good news that we still continue to offer this fantastic service. You know, it hasn't stopped. It's still there. We still care about our residents and want to support them to recover their health.
Yeah, I think that's a good idea, because I know we've reviewed what's in place now against what is across Berkshire, and it's still the better service in Wokingham than anywhere else. It's just that we've mismanaged the transition.
Can I just add as well that the numbers of people who communicated with me that I reflect there include carers, community support groups as well. It's not just the individual who has attended.
I think, as Rebecca said, you know, we all go out and talk to people on the doorsteps all the time. So we are aware that there are people who were very concerned, but they wouldn't have necessarily written to you. And we wouldn't necessarily have encouraged them to do that, because we were able to tell them that although there had been a problem, it's moved on.
Can I say on behalf of the committee to you sitting on there, I know how many hours that you've spent on this in the last, I can't remember, it was a few weeks or a few days. It feels like quite a long time. And I know Caroline particularly worked over the weekend because we spoke to each other. And thank you. I hope we've now got to a point where that issue is closed and we move forward with the new programme, and hopefully we'll have a way of getting that out into the public domain in a successful way. So thank you to all of you for your hard work and for taking the pressure from us, because that's what we're here for. We want to find out what's going on. Thank you very much, and we will move on to the KPIs. Sorry, I can't read this. Oh, sorry, I'm not even using the agenda. Let me read them out from there. The recommendation is that the Health and Overview Scrutiny Committee is asked to note the lessons learned. I think we've done that. Acknowledge the comprehensive response to the addresses issued. And I just hope I've done that with the members of staff that have worked so hard on it. And note the collaboration with Places Leisure, building on the established strategic partnership. Thank you. If you could all note that's what we've done, and we wish the new service all good luck in the future. Thank you. Let's move on to the KPIs on page 51.
I think that might be me again. Sorry, everybody. You've got my voice for another few minutes. So you will have seen the KPIs, and just because of a timings fluke, you'll remember that at the last HOSC meeting, you received the last quarter's KPIs, and because of the way the timing goes, this HOSC, you've got the next quarter KPIs. And what I've actually done is I've got a few slides, because last time we had a bit of a discussion on the 0 to 19 programme, in particular around health visiting at for pregnant women. And one of the questions I was asked was, why does Bracknell Forest have a much more significant apparent contact rate than we do? So what I've done is I've put some slides together that I hope will explore this a little bit more. And by some also fluke, we've got Q3 data in the slides. You know, the timings don't always matter, but you're getting a heads up on the next time the data come to you, you'll have seen it already. So there we go. Right, let's open this up. Move that down. So this is all about the Healthy Child programme and the 0 to 19 service, which is a health visiting and school nurse service. So it supports children and young people. So our aim is to deliver, well, we're mandated to deliver a certain number of health visiting contacts from pregnancy through to 2.5 years old. 5 contacts. So that's the 0 to 5, and then we have the school nursing offer. So the aim for us is to make sure that everybody gets a universal offer of support, information, but that we also can provide additional support where there are people that are identified as having a more complex situation. And that could be complex physically because of the birth, it could be complex socially, it could be complex from the health of the mother or the environment that the mother lives in. But it's important that we can identify those needs early so that we can put things in place to provide support for babies and children. Somehow this is not going over because I've got something going in. Bear with. It's not moving. Okay. So this is the key slide that talks about mothers receiving face-to-face contact. So this is that the KPI that caused a lot of discussion last time. And you can see that, so the aim here is that pregnant women receive a face-to-face antenatal contact with a health visitor when they're 28 weeks or more pregnant. Those pregnant women will have contact with many, many services linked to their pregnancy. That's not to say that they shouldn't have an antenatal health visitor contact, but if they are seeing another healthcare provider, they may not consider it particularly important for them. So we really try to target those women that we think could have the greatest benefit from that contact. Now, what I've got here are the last 4 quarters data, and you'll see there we've got Q3 data, which isn't in the pack because it's new. And we've got varyingly 55, 38, 43 or 24 face-to-face contacts. Now, what I'd like you to look at is within regards to the pregnancy notifications that have been received, because that starts to tell us a different story of proportion of people who are being seen. So we've got 257, 182, 399 and 144. Now, the issue for us, we commission this service. The issue for us and me is we have approximately, we can only proxy estimate it, but we have approximately 400 babies born a quarter, 1,600 a year. So we've got a position here that Q2 wasn't too bad in terms of pregnancy notification review. That's pretty much what we would expect to see. But all the previous quarters and this quarter feel low. Now, I can't say 100% that that is a low number, but it feels low. It doesn't link to what we would expect to be seeing. And so we're working with BHFT, our provider, to really understand what the reality of that position is. And that work, we've been working quite closely with BHFT on trying to, encourage more women to take up the offer of a health visiting contact, but also to understand what the data are really telling us. Is this an accurate picture of what's really going on? And that's really important for us to find out, because we need to make sure that every time we have a notification of a pregnancy, we are triangulating that with information from a GP, a midwife, as to the need of that woman to have further, whether or not she might need more support. So that's really where we are at the moment, is trying to really bottom out some of that information. But I want to go back to that question we had last time about Bracknell Forest, because what we see here is that we have 21%, 20%, 10% and 16% as a proportion of pregnancy notifications where the woman received a face-to-face contact. And I was asked why we didn't have 100%, because that's what Bracknell Forest has. Bracknell Forest... Sorry, go ahead.
I was the one that asked that question. I never asked why were we the ones that didn't receive 100%. I never asked that. I actually said, why are they doing so much better than we are? I never said that. So I'd just like to raise that as a point. Thank you.
Okay, that is true. You did that. You did say, why are they doing better? If you look at the Bracknell Forest data, it says they have a 98% contact and 2% face-to-face. What we understand from the Bracknell Forest data are that their offer is counted as a contact, and we don't count an offer as a contact. So all our notifications, all our pregnancy notifications, receive information about the health visiting service, but not all of them received a face-to-face contact, only the 24, 43, 38, etc. So 16% Q3 received a face-to-face contact. That's pretty good compared to 2% from Bracknell Forest. So I just want to kind of, this is about a difference in reporting and how different areas report on those elements. The other thing I just wanted to confirm is it was suggested that we had, or that Bracknell Forest did a rate per child tariff in terms of how they saw, but they don't. It's a block contract. So the contract says, this is what we'd like you to deliver, because that's what we weren't really sure about.
Well, that's what I was told by Jyoti, the previous director for public health. I've actually got it written down, what she told me the cost per head, and that Bracknell Forest were paying over £10 more. And I did say to her at the time, per head, well, that's a big difference, but why they do, it still doesn't equate for the figures that you're telling me, then they're doing massively better and we're not. So again, poor information coming out. We're not getting a clear picture of what's happened. And I know you're telling us what these figures are, but we haven't, you're talking about Bracknell Forest now. There's nothing on paper here. It's just what you're saying, 2%. It would be nice if maybe, if you wanted to explore that with us, you could put it in proper papers so we could read it. Because, you know,
I mean, I'm not here. I'm not here to performance manage Bracknell Forest.
No,
so I followed up with Bracknell Forest as I was asked to do.
Caroline, I take a little bit of offence.
Sorry, I'm not. It was no offence intended.
No, I do take a bit of offence to that because at the end of the day, we have a KPI here that for the last 4 quarters is declining, and it is our job to question why it's been declining. Yes, it's slightly improved, and I'm only speaking about the information that's put to me, and I was told by the Director for Public Health. It's nothing about performance management to do, and expecting you to do that, but we are asked to be on this overview and scrutiny committee to look at these figures. And I'm only asking and highlighting figures to me that my residents would say to me if they read this, would say, Rebecca, why is nobody doing anything about this? These figures are declining. So I take a little bit of offence to what you say because I do not feel I've asked any question that's been unreasonable.
We're absolutely in support of investigating and understanding this activity for Wokingham Borough residents. Absolutely, and that's what we're here to do, and that's what we are doing, and we have regular commissioning meetings. One of the things that this contract comes up at the end of March 2027, so we're looking to reprocure it, and we're reprocuring it just for Wokingham. So at the moment we have a joint commissioned service with the local authorities that make up Berkshire West. We're looking at reprocuring this just for Wokingham, which will make it much easier for us to unpick some of this data. BHFT, they're actually online today. We're working very closely with them to try and get beneath this and understand. I mean, the real issue for us is that we understand where we can put the interventions in place that will really support our residents and bailies. I'm going to go through because there's a couple of other points. And
Could I just interrupt now, because I think by comparing ourselves with other authorities, we're using X and P's, and we're going down roads that have no comparison at all. And I think we need to stop doing that. And I know that residents you've got residents on the border and all that sort of thing, but I think we need to not take our time up doing that. Okay, if we could, thank you. I've got a couple more speakers. Yeah.
Let's make a suggestion that if Caroline's offered that information about Bracknell as additional to what she would normally report, I think if the committee actually wanted information, they should ask for the information, and the information will be provided in the report. But as I understand it, you've just provided them with some things that you've done extra work on. So I think it's a little bit unfair to criticise it for not being in the report when it's nothing to do with us, but it was offered to you as extra.
Want to come in?
Well, I mean, do people want to come in now? I mean, that's fine.
Yeah.
Yeah. Somebody's online first. Okay.
So this is Helen, who is from BHFT.
Yeah. Helen, would you like to go now?
If that's possible, thank you. I thought it might be just helpful. It's probably just reiterating what Caroline has said, but I think there's a few things that I can provide as the provider that might help with some clarity, because I think, actually, Caroline, can you leave the figures up? Because I can talk to them then, sorry. Because actually, I think it's understanding the antenatal route. So the referrals come through to us as a provider from midwifery. So we get all of the referrals. Now, up until recently, those have been coming through via email and haven't been consistent and reliable in the way they have come through. We have now built in Berkshire Healthcare via a system called Document, a new digital way of receiving those referrals, which means that those pregnancy notifications, we hope in Q4 will be much more reliable. And as Caroline has said, will be much more closer to the 400. That's what we're anticipating, because that's what we feel that the data isn't showing us. In terms of the mothers receiving a face-to-face contact, when that referral comes through to us in Berkshire Healthcare, a trained health visitor will look at each of those referrals and decide at that point whether a mother and the family actually require a universal support, which would be, as Caroline has said, a digital contact. It's an email that's sent out to all families, giving them support and advice and inviting them to a group if they want to come to a group, or those mothers where we feel actually there's a level of risk or an area of concern, and actually we want to go and do a home face-to-face contact at that point in time. For Q3, that was really low, and that's a trend that we would need to follow, because it is unusually low, as you can see. What we're moving to for that universal offer is actually also looking at putting something online on our website. So actually it will be a live session with a health visitor talking that mothers can actually watch at their leisure to give them that support as well. So I think the bit that's missing on this table, and that's something that Caroline has alluded to, and we will be able to report from Q4, is it's the percentage that received the face-to-face, and we need to make sure that those are the families where we've identified them as requiring a targeted approach. But the number that's missing is all of those that received the universal offer, which is the digital. And I think that will then give the percentages much more, it will make much more sense, because actually it is that everyone is having an offer. It's just on here we're focusing on that targeted and face-to-face, which actually 16.6 is actually a very good offer for those targeted families. I'm hoping that helps a little bit.
Thank you, Helen. Adrian, would you like to ask a question now?
Yeah, I mean, I think, you know, we can trade numbers and talk apples and pears, and that doesn't make any sense to anybody. I think what we should be doing, like the coroner service, where we procure a service, we get the coroners to present their service. We should get these guys to present their service. That would be my takeaway from this meeting. There's no disrespect to you, but you're not delivering the service. You're just commissioning it. So can we have an action to include this in a future meeting so that they come and present their service? And, you know, you're very welcome to appear, and we would like you to appear, but they should be saying, these are the numbers, this is how we get to the numbers, because they're really their numbers, aren't they?
They are their numbers. I mean, because we commission the service, we work with them to monitor how that's going, and we have a responsibility to do that. And that's what we report in our key performance indicators, which is how it's come to the board. But yes, you're absolutely right. And it would be great to work with BHFT to have a presentation of their kind of, and it was really helpful to hear Helen's programme timeline of what happens and how that works. So, yeah.
Yeah, I think, you know, we in any scrutiny committee, we're trying to peel back the onion, and you need the right people in the room. I appreciate them being online, but it would be even more helpful if they were the focus of the presentation.
Question, Maggie.
I just had a comment on the previous one, Chair. When Rebecca was trying to get Bracknell, I think it's okay to compare. I know, again, we went down the line, but I don't want to kick off the room, but in many of the recent meetings, we have comparison with Blackpool Council as well, okay? When things are not looking great, you get to compare with them, and when we are talking about something good, we don't get to compare. No, it's only, I mean, again, she didn't ask any harsh question. It is about explanation. What Caroline absolutely was on spot on. So all we wanted is something in written so we could get better understanding. And the action for next quarter, where we've got to bring it to the Wokingham service alone, which is a good way to go forward. So everything is in the room. It is just that, us agreeing to it. Yeah.
Yeah, my concern with that is that we're comparing apples and pears. If we're comparing things, they need to be like for like.
Right, okay, the complete madness to me seems to be that the KPI target is 300. Now, the capacity issue means that we're only aiming to do targeted. What we need to see in your KPI is how many women were targeted, was it 30 women were targeted and we gave it face-to-face to 24. You're never going to achieve a target of 300. And I mean, Amber is 100 to 299. So how soon are we going to completely change this KPI to make it achievable and meaningful?
That is a spot-on question, because we don't have national targets associated with this. And this is our set target. And if you say that the target we have is the people we have a digital contact with, then we do achieve that. It's just that we're not recording that. And that goes back to what Helen was saying, how we're recording this data. So we are revisiting the specific KPIs that we have, and that will be by the end of this month to feed into the year 26-27 revised KPI target programme.
Thank you. Alice, you have your hand up.
Yes, thank you, Chair. Helen, I just wanted to find out from you, how do you communicate with the women about what health visiting service is about? Because things did change during COVID. There were less visits and things like that, and not many people knew what health visiting was about. So who shares that information?
So that there's various ways that we share that information. So that will be shared through the Berkshire Healthcare website. It is shared at once a pregnant mother is 28 weeks plus, and we have the referral from midwifery. Then there is a detailed letter that has been jointly written by Public Health and Berkshire Healthcare that's sent to all families. The midwife obviously also shares that information, as does the GP. But also we work very closely with it's family hubs, and we're very much working with the Better Start in Life work, because it will be essential now that we're sharing that information as well. And we go along to talks and those kind of things as part of our public health role in health visiting.
Can I come back to that, Chair?
Of course you can.
Chair, it's okay. One of the things that is very concerning for us is that people put letters out there and assuming that people can read. And I think there's a lot of assumptions made out that the public knows about health visiting. I do encourage you all to put out a little bit more information and please don't make assumptions that other services are sharing that, because we sort of did a spot check and we found out a lot of people were not aware of what health visiting is all about.
Yeah, if possible, I'll just reply to that. It's because we have across the West as a whole, as Caroline said, there's a contract across the West. We have non-attendance at some of our appointments, and we need to understand why. And as a service at the moment, not in Wokingham but in Reading, but we will share the learning. We are doing a quality improvement piece of work, exactly that, looking at why are some families non-attending, or do we have families who are non-attending different appointments of the 5 mandatory appointments, or is it just one, and why are they? So there's some learning coming through already, and what we want to do is then apply that across, and then we will dig deeper if we need to in each of the local authorities specifically. But I think it's a valid point. Our website, you can translate on it into different languages, but I think you can't just rely, I agree, on written information. Absolutely.
Thank you, Chair.
could I just ask about this KPI definition? I think this is half the problem. I know Alison has talked about it a little bit, but it does say as part of the nationally mandated Healthy Child programme. And you keep saying these are not mandated, but this is what the information says here. This is what this KPI definition is, and it should conduct a face-to-face check with women at 28 week of pregnancy. It actually says this here in front of us. So I do have a concern. Are we actually meant to be seeing women face-to-face? Is this nationally mandated? Or are we going to just change this KPI so that we meet the target because we're going to be talking to them instead? What are we meant to be doing? Because this is confusing. You've got this written here saying it's a nationally mandated Healthy Child programme.
It is a nationally mandated Healthy Child programme, and that comes with guidance as to what that means. There is no nationally mandated target associated with that particular KPI. So that's the
so it's nationally mandated that a health visitor should conduct a face-to-face check with a pregnant woman at the 28th week of pregnancy. That's what I don't understand.
There's an offer. But so there's a difference between an offer and an uptake. That has to be, that the offer has to be there.
Sorry, I thought the offer was only being made to women who were targeted because they'd been identified as particular risks. I didn't think every single woman was invited to have a face-to-face if she wanted it because of lack of capacity. That was how I'd read the narrative.
So the information goes out to everybody. Helen, do you want to clarify that?
Yes, so the information goes out to everybody, and we currently run antenatal groups, and then anybody who hasn't been identified, who is, as we call on the universal caseload at that point, is welcome to actually join those groups. But at the moment, we have very low attendance at those groups. And so that's why we're looking at maybe a digital offer where, you know, listening to what our mothers want and actually being able to, something that mothers can actually access online and join that way, that is interactive. So there is an offer to everybody.
Can I add to this here? When you're looking at who comes, I have 4 children, and the first time I hadn't a clue what was going on and took everything that was offered. After that, I knew a bit more and sort of got on more on my own. Would it be useful to classify the first-time mothers so that we could explain away some of the non-involvement of second and third and maybe more time mothers?
I think that's a really interesting point, and that's something we really want to understand better about why people don't come for a visit at any one of those offers, because as we already discussed, you may have people who don't understand what the invitation is saying. You might have people who are so familiar with having children, they really don't need to have that anymore. You may have people who simply can't make that particular time. And I think it's really important that we understand why people don't come for their health visitor check, particularly at the kind of later checks as well, when we can sense or understand more about the level of development that a child might have and what might start to go into place to provide additional support. So I think that's a really important point, Beth.
And then Alison.
Yeah, just one comment. I understand that some mums will be busy, they will be full-time working, they will potentially want digital contact, but I don't want our service to hide behind a digital contact. Sending an email to somebody and saying that's an offer, and we've offered 99.99% of people, it doesn't give me any comfort whatsoever. You know, it's very, very important, especially as Councillor Rowland said, for the first child to really have a face-to-face contact, and that really has to be followed through. And I think that's I think I think you're going in the right direction, but I want to see a much higher percentage of face-to-face on first births.
So just to say, this is about the antenatal rather than the postnatal visit. Just see it, yeah, but this.
Alice, in her work with the South Asian women, highlighted the call for more appointments, possible evenings and weekends, you know, with people working. I know myself with my children, when I went to antenatal classes, they were offered in the evening, you know, so you could go to them while you were at work. Are these health visitor groups offered in the evenings and weekends?
Shall I come in there just to say, yes, they have been, but with sadly very poor attendance. It isn't something that's been well attended, unfortunately. But again, this is something that we're looking at the moment. Can I just come back to the previous comment that was made around the digital contact? Because I think it's important. One of the things that I think we haven't explored here is these are mothers who are at 28-week gestation, and actually they are still under the midwifery service, and they are under the midwifery service until they leave hospital, which is when they then come to the health visitors caseload. So a lot of the women and mothers have said to us that they don't see the need necessarily, as long as they understand the health visitor service, they are having their support from the midwives, and we work really, really closely with them. And that actually it is then that new birth visit, which we are mandated to do within 14 days of the child coming home, that actually that's the important one, where the health visitor will actually do more face-to-face, you know, that it's a face-to-face appointment in the home with the family. I'm hoping that kind of clarifies a little bit. It's not that these families aren't having anything, they are still under the midwifery service at that point in time.
And if I could just go into that newborn visit, in quarter 3, 91.2% of babies were seen within 14 days. And then a further 7.9% were seen just over 14 days. So very much that face-to-face new birth visit is very much higher.
And I think it's we benchmark. So if you look at and again, it's not all about numbers, is it? It's about the experience of the mother and the baby. But just if you nationally across England, the national average for the new birth visit within 14 days is 85.2%, and in Wokingham in 2024-25 it was 89.5%. So I think that's just to give you the benchmarking alongside that for assurance as well.
Thank you, Helen. Thank you, everyone. Let's move on. We've still got quite a lot to look at. So page... Sorry? Oh, sorry, Alice. Your hand.
Sorry. I just wanted to highlight something that, and I appreciate that the 28 visit is important, but one of the biggest things that we talk about is the first birth checks and all the kind of, but mothers do turn around and say that people concentrate on the babies, but not the mother. The maternal mental health is not being looked at. And I think an opportunity that health visitors have is to capture, because the Embrace report says 18% of women die by suicide in the first week of the child's birth, kind of thing. So I do think this is important that that is highlighted. It's not only the GPs that do it, but also I think we have got 3 professionals here who could have stopped a lot of the and who could have captured women with mental health problems.
Disturbing figure, and perhaps that's something we need to look at again in another meeting.
Yeah.
Thank you.
I'm trying to work it out. It must be is it 18% of people who take their own life are
Yes,
in the
yeah.
first week. It's not 18% of new mothers.
No.
No,
Just
it's the first year of the child's birth kind of thing. So if you turn around and look at when the child is 1 year old, we are losing mothers just like that, whereby a lot of the time it tends to be that mothers are not caught early enough to address the mental health. And women have turned around and said, so our 2023 report turned around and said, all health, professionals are concerned with is the baby, not the mother.
I mean, I think it is a really good and valid point, and we know that mental health issues are increasing across the country, and Wokingham is no different in that. So this is absolutely something we will need to explore further.
I'd just like to ask a question. Would it be the same health visitor that sees the mum to be at 28 weeks that also goes to visit her within 2 weeks of giving birth?
Shall I answer that? Not necessarily. Wherever we can, we try to ensure consistency, but it won't necessarily be the same health visitor. We don't have the resource of health visitors to be able to do that because there are other responsibilities for health visitors as well. So I can't say that would be the case if we can. Specifically for those that are on our targeted caseload, that are those families where we're more concerned, we would aim to keep more consistency there so that there's a relationship that builds. I also wanted to say around the mental health. So health visitors do receive training. We have in the wider Berkshire Healthcare, we have the perinatal team, which actually also sits within my remit. So the perinatal team will train the health visitors and the health visitors train the perinatal team. And they work very, very closely together. And absolutely a health visitor, there is a focus on the baby, but the health visitor will also be looking at the mental health and maternal mood of the mother as well on the visit.
Can I also ask, are all our health visitors qualified? Because there is mention in the narrative of PH2 that if a family declines a new birth visit, they'll be contacted by a qualified health visitor. And I just wondered why that word had been necessary.
So there is a skill mix within the team, and recognised a health visitor is of a certain grade and has a certain qualification that they come to. But we have a skill mix, so we also have nursery nurses who who work under the supervision of a health visitor, and also staff nurses that work within the service. But they have clearly defined roles and responsibilities, but it means that clinically the health visitors have actually gone through specific training to actually be a health visitor. That's what it refers to.
Okay, let's move on. Anything else on PH2? PH3? Can't get the figures over for. Complete change of subject. Now we're on to stopping smoking. No. PH5, drug and alcohol. Page 67. Proportion of adults in drug and alcohol who are discharged from treatment for unknown reasons. PH6 is adults completing alcohol treatment. PH7, integrated sexual health services. PH8, service uses offered and tested for HIV. PH9, community wellness outreach sessions. Nope. Next, adult services KPIs. Matt, are you doing that?
I am. I just want to make it. You did. We're quite steady, in terms of we bring these, ever so often. So the ones that everybody is used to, and this is Q3. What I did want to say is, and you have to humour me a bit here, so I'm going to go a little bit off piece, but it is linked. I want to draw people's attention to the Casey review of adult social care. I think most of us will know that what the government is going to do or how it's approached reforming adult social care is to commission Baroness Casey to do a review of adult social care. In the first year of that review, she spent a lot of time going out listening and understanding the state of adult social care. Last week was her first speech summarising that. I don't know who here in the committee's heard that, but I'd like to distribute that to the committee. It's a YouTube speech, and it'd be nice if people could listen to that. It was quite an honest and frank description of the state of adult social care. I won't go into all the detail of that now, but she talked about fragmented, underfunded system reliant on low-paid care workers, held together with sticking glue and plaster. And I suppose the next year is going to be really important as that now then builds out into a conversation, a national conversation about what to do. At the end of this year, an interim report will be produced, and then in 2028, the full report. And I know she talked a lot about trying to make this a kind of cross-party consensus around how to fix adult social care. So I wanted to just raise that and get the committee's sort of engagement in that. What's that got to do with KPIs, you might ask? But I suppose I'm really worried. I'm quite proud of the performance of adult social care in Wokingham, but I know these things that Baroness Casey has pointed out are issues day to day for our staff. I know between 2024 and 2034, there's going to be a 37% more over 80s in the borough. I know that many people, a huge percentage of the adult social care workforce, maybe me included, maybe not yet, are pretty close to or getting into that kind of run into retirement. There isn't the staff to replace that. I know that the Fair Funding Review hasn't sorted out the funding problems in adult social care. So I'm really worried, and I do feel the time is now to tackle this as a society. So I just wanted to make that, turned into a bit of a longer speech than I thought that. But that for me is the context in which these KPIs are delivered. So I just wanted to bring that to the committee's attention. Happy to take questions though on the KPIs.
Rebecca.
Sorry, I felt like I need to apologise the way you looked at me then, Beth. The AS7, I'm obviously aware that it's remaining within target about safeguarding, but it has declined. The proportion of Section 42 safeguarding inquiries where a risk was identified and the reported outcome that this risk was reduced or removed. It's obviously within target, but safeguarding is such a significant issue. And kind of some reassurance from you that it's not going to continue to decline and hopefully not go into amber. I'm sure it won't. But what steps are you doing to try and keep that one on target? I know it is in target, but it's declining, if you see what I'm saying.
So just for everyone in that service, I mean, when we were inspected by the CQC, that performance, or every other council in the country would I'm trying to find the right expression now, would be delighted, I'd put it that way, to have that performance. Maintaining it, though, is really important. And as you can see, if you look at the numbers below, 179, the volume, so that's 94% of a much bigger volume. And that's been the issue in that period. We're not seeing that volume continue, so I'm hoping Q4 that'll bounce back up a bit. But I mean, the bottom line is, if that did start to drop and crumble under the volume, then we'd have to redirect resource or find more. You know, safeguarding is not something you would want to deprioritise in any way.
Yeah, I'm struggling with KPI number 2, the percentage of new contact referrals closed with advice, information or signposting. So it's kind of flatlined for the last 4 quarters, well, it's still above target, but that had been a much higher figure, but it's kind of without context. So I don't know how many people in Q1 24-25 were actually referred, of which 39% were closed out. So it could be 20 people of whom 4 were signposted, but it could be a completely different figure. Then if I look forward to the Q3 25-26, where it's 25%, it could be just 4 people referred, 1 of whom was closed out. So it's a KPI without context. And in the public health ones, usually in the narrative underneath, it gives you the numbers of people related, so you can work out that context. And I'm kind of thinking, well, it could indicate if the referrals are effectively related to over or false diagnosis, then the number probably goes up, and that's not a good thing. And in that we really want better, more accurate diagnosis. Or whereas maybe the number's gone up because WBC was tougher in turning people into info and signposting rather than taking people into care or giving them more care. So is higher better, I'm wondering. So I'm sort of struggling, what's the KPI trying to tell me? It's a bit of a ramble, I'm sorry.
No, that's okay. There's just quite a few bits in there. This is a tricky one, but for me, higher is better. The reason higher is better is because I want more people to contact us earlier, in order that people don't wait till they get to crisis point, so that we can make sure people are signposted on to those voluntary sector services and those prevention services that we so that's the strategic aim. I do agree it could be a bit clearer about that in the KPI, and we'll do that. That is a little bit counterintuitive, because some people would say, well, you want to reduce your contacts and only have contact people who really need your maybe your statutory service, but here that's not what we're looking for. The reason the numbers, if you can see on the little table above, the kind of numerator and denominator, just to get a little bit technical but not too technical, are there the actuals, if you see underneath the figures. But what we haven't got on here, because the chart below goes back to show a trend over the years, are those numbers for all those percentages. But we can go back to the reports and find that. The reason it's gone down, we think is the percentage that has gone down is twofold. There's a training issue in that it appears that a practice came in with recording that wasn't ticking the right bit on the system that showed that something had been signposted. That's been corrected, so we should see an uptick now. But also, we revamped our website in Q4 or Q3, Q4 of last year, and we've got things on there called Ask Sarah, which is like an OT interactive chat thing. So we're feeling that more people are using that rather than contacting us, therefore not needing to be signposted to that as well. But it's because we want to focus on that, on trying to get people to contact us earlier in their journey towards care and support.
Just having a look what else we got. That's it. Thank you very much, everyone. Have a safe journey home. I hope it's warm outside, but don't think it is. Melanie, nice to see you. Getting back to normal, possibly.
Thanks, Anna.
I've no idea what
Thanks,
normal
Anna.
is. I don't want to know. Yeah. Yeah. Yeah.